In progress.
Here at Spectrum Health, we're working closely with our resident programs in internal medicine and pediatrics, as well as family medicine, to help them learn more about the direct link between food and health.
Blending the art of cooking with the science of medicine is very important because there's a lot of good research out there on the impact of healthy nutrition or better nutrition on health outcomes. But many healthcare providers have no idea how to work with that science of nutrition and actually translate it into healthy eating behaviors.
Students learn the nutritional science, they learn how to create healthy recipes, and they learn culinary skills. And when you combine the three, they can really translate that into their home kitchen.
It's important to bring medical students into the kitchen to show them cooking skills so they can become comfortable and confident themselves. Once they understand how easy it is to prepare a healthy meal from scratch at home, they then can turn around and bring that to the patients and empower the patients to do the same.
When patients hear me talk more candidly about diet and nutrition, they're actually pretty surprised. Most physicians don't get a ton of formal nutrition education, especially after medical school, and they're surprised to learn that I'm very interested in helping them achieve a healthy diet and learn how to live a healthier life.
We are seeing and treating diet-related disease and really need to find an innovative approach as to how we talk to patients about food and its direct link on their overall health.
When we bring a medical student into the kitchen, what we show them is practical skills they can use not only at home, but by teaching them practical skills on food preparation, we teach them also how simple it could be to work with fresh produce and fresh ingredients and plant-based ingredients.
I have several patients and their parents who ask me questions in the office about healthy eating and how to incorporate healthy foods in their diet, and I knew that this would help me get there.
Eating better food myself helps me to talk to my patients about diet and nutrition because I'm a better example for them.
We're really talking about behavior change, which can be very challenging for patients, and we know that it's hard to make changes in our own lives. Our ability to talk to medical students and help change their behavior, they're then more likely to talk to their patients about it as well.
Culinary medicine is not a gourmet cooking. It pairs the art of food preparation and the science of medicine. It is the practice of helping patients use nutrition and good cooking habits to restore and maintain health. It's about teaching the why and the how behind low-cost, convenient, health-promoting, and delicious home-cooked meals and healthy eating patterns. Culinary medicine offers a simple approach to understand how food and cooking relate to personal health, behavior, and healthcare goals. It is as much about learning which food reduce inflammation and promote melting of cholesterol plaques in our blood vessels as it is about how to properly slice the onion and cook food with rich flavors and enticing plate preparation. More importantly, culinary medicine offers individuals an opportunity to practice culinary skills and taste new recipes alongside with health education. And all of which is taught in a way that effectively translates to their own home kitchen. The objective is to educate about the powerful influence that food has on health and disease. The goal is to establish skills in preparing meals with nutritional benefits and develop the habit of being a smart consumer, someone who would always consider what follows after every swallows. The curriculum is designed not only for healthcare providers, but most importantly, for patients and their family. culinary medicine is purely an evidence-based field of medicine. In fact, a growing number of medical schools in the United States are increasing the education provided to their students on clinical nutrition and bringing medical students in the teaching kitchen. As we speak, more and more medical practitioners and lifestyle medicine service providers are seeking the certification in culinary medicine. And now, the Philippine College of Lifestyle Medicine finally brings culinary medicine certification course in Asia. It is a program with a blended curriculum composing of online and in-person modules that anyone can finish between 6 to 12 months at their own pace. The online component will provide foundational knowledge in culinary skills, behavioral coaching, and clinical nutrition for specific group and specific disease. There will also be a remarkable emphasis on chronic disease prevention and reversal, such as diabetes, heart disease, dyslipidemia, basing on published evidences. Bottom line is, culinary medicine is a course that should be taken by anyone who has the risk or who already have the chronic disease, where the cost is mostly within the control of our lips. See the link, register, and get your kitchen ready.
My name is Cora Paniergo Robles. I am a widow. I am 60 years old. It is a great honor to be invited to share with you my amazing testimony on how my life changed. A few years ago, I was in and out of ICU for multiple fatal health condition. With its ICU admission is a unique case. And if I have to specific about it, I suffered from sepsis, chronic obstructive pulmonary disease, stage 5, chronic kidney disease, and hypokalemia. I am also diabetic with an ortho issue. There's a favorite word other people used about all this diabetes or this that is irreversible. In those years, it was like a constant tug of war with death. As a single parent and a major breadwinner, my condition is basically one-way ticket to comorbid depression. It is also doesn't help. I was still navigating my way through emptiness syndrome as my children have started living independently as full-grown adult. While I was confident how I prepared item to face the world on their own, I realized I was not prepared myself. Until my life turned 180 degrees, I found myself enrolled in a lifestyle management course facilitated by none other than Dr. Mechelle Acero Palma. All this time, I was bombarding myself with medicine for all of my symptoms while completely ignoring the root cause. A terrible lifestyle. I was a chain smoker, 3 packs of Philip Morris a day, coffee. Even I don't eat my regular food as long I have coffee and cigarette because I am holding 6 hours program a day. So I am solved with smoke and coffee. I had erratic sleep schedule and a toxic work environment which demanded so much physically and mentally. You know, the work of media, the time. As of now, I am go for my retirement this year. It is through this intervention that I completely changed my outlook in life and my relationship with food. Food is your medicine. I cannot forget that because that is Dr. Palma told me. Food is your medicine. Okay, my body, my thoughts, and even my faith. With constant guidance of Dr. Mechelle, I was able to defy all odds of what they say was irreversible. Citing samples such as laboratory result. All of my other doctors seems to be constant state of surprise in every visit because of my progress. Before, my prayers would sound like, Lord, bahala ka na. Nowadays, my prayers are no longer sober, surrender. Instead, I pray in gratitude for having this beautiful second chance. And with this, I vow to use this opportunity to maybe even save others' lives by being an instrument, a living proof of the many miracles lifestyle medicine can do. Thank you very much.
All right, good evening, everyone. I'm Dr. Mechelle Acero Palma, the founder of the Culinary Medicine Asia. So I'd like to thank you for joining me tonight for this webinar series. So we have two scheduled for March. So we will be talking about food first approach for chronic kidney disease. So to those of you who are enrolled in culinary medicine courses, both for basic and professional course. This is one of the activities where you can gather your CME credits. And to those of you who are just joining us today, or for those who are first timers here in Culinary MD, I'd like to welcome you again. Thank you for joining us. You can always visit our website and click free resources. So you can actually find a lot of recorded webinars that we have had in the past. And to those who missed the past webinars, you can also visit the website, go through the free resources page, and then so that you can access the past webinars. Okay, so again, like I said, we'll have two series for this month. The next series will be, the next schedule will be March 26, 2023. So to those of you who are enrolled in the professional course in lifestyle and culinary medicine, you can gather credits from this activity. This is just a reminder, if you are aiming for the certification exam, that will be conducted for this year, then you have to gather the CME credits. And of course, you also have to gather credits for at least two live in-person culinary medicine workshop conducted by the Philippine College of Lifestyle Medicine. Of course, you have three requisites, right? You have to complete your online culinary medicine professional course and then join at least two live in-person culinary medicine workshop conducted with the PCLM, and then join at least 8 live webinars conducted by Culinary MD. So this can be one of those credits that you have to gather. Okay, so for the PCLM events, there are 2 upcoming events that you can join. So that's mid-year conference, July 16 to 18, that will be in Davao. And then the last event will be the annual convention, that's December 3 to 5, that will be in Clark, Pampanga. So to those of you who are not yet into culinary medicine training, you may want to visit our website, take the free course first so you got the taste of what culinary medicine is. And if you're interested, you can avail and apply the scholarship grant both for basic course and the professional course. So for tonight, we'll be talking about the topic in chronic kidney disease. So you can find this in your text, in your handbook. If you're holding it right now, the page would depend on the format of the book that you're using. So because we have three formats for this book, we have the hardcover, we have the paperback format, and of course we have the ebook format, which you can get from Amazon. So that will be in chapter 8. So the kidney disease trend. So to those of you who are enrolled in professional course, you can find this in your online modules, and this is under cluster 3 modules, particularly unit 2. So that's chronic kidney disease right there. Okay, to those of you who are joining us for the first time, would like to introduce to you lifestyle medicine. This is where culinary medicine is being utilized as one of the modalities under nutrition. So here are the 6 pillars in lifestyle medicine. We use the 6 pillars as primary intervention for chronic kidney disease, specifically reducing cardiometabolic risk. So we use physical activity prescription. We also use restorative sleep, social connection, avoiding risky substances, stress management strategies, and of course, they're all important, but nutrition covers like over 60% of the management we provide in lifestyle intervention. And as I've mentioned, culinary medicine is one of the modalities we use. So culinary medicine is a combination of medical science and culinary skills so that we can evoke behavior change to patients so that they can develop culinary skills and achieve optimal health management. Okay, now let's jump to our topic for this evening. So that's food first approach for chronic kidney disease. So we know that chronic kidney disease is actually prevalent worldwide. And as you can see, for those who are aging 65 to 74 years old, 1 in every 5 men are affected, 1 in every 4 women are already affected. And by age 75 and over, you will see that the prevalence increases, 2 in every 5 for men and 3 in every 5 for women. Now, Philippines is no exemption. In fact, in this report in 2022, you can see that Davao City actually ranks 3rd, among those who have the most number of kidney disease. Now, kidneys are actually performing at 100% health, but by the time we reach 36 years old, so that means each year means less than 1% of functionality. So therefore, if you look at the loss of kidneys functionality, that will be 20% loss of kidney functionality by age 55. So if we look at the prevalence in the Philippines among patients or Filipinos with chronic kidney disease, the latest estimates show that around 2.3 million Filipinos have chronic kidney disease already. So in 2016, there are more than 36,000 patients who were in dialysis treatment. That actually reflects a 15% increase in the number of patients in just 1 year. That's why we always say it's really exponential. Now, when you look at this figure, this will only tell you that this is how our kidney functions. So like I've already said, it should be 100% functioning, but beginning at age 36, the function of our kidneys are expected to decline. So for a healthy individual, our kidneys can actually filter fluids at about 100 to 120 ml per minute per 1.73 meters square of our body surface. So this is slightly less in women, and it gets lesser as we age. But to those who are hypertensive, they lose 2% of the functionality of their kidneys each year. So remember, for healthy individuals, it is estimated to lose its functionality at 1% beginning age 36, right? But for those who have hypertension, they are expected to lose 2% of the functionality of their kidneys each year. And of course, among patients with diabetes, they lose about 5% of the kidneys functionality per year. So the 2 most common cause of chronic kidney disease is diabetes and hypertension. Number one is diabetes. Number two is hypertension. But there are also other causes like systemic diseases like lupus, erythematous, rheumatoid arthritis, infections, the use of medications. That means this is over-the-counter use of drugs like NSAIDs and other medications as well. And of course, the use of toxins, toxic substances like tobacco. Now, kidney disease is also what do you call this stage, depending on the glomerular filtration rate. So a chronic kidney disease afflicted person's kidneys cannot actually properly filter the blood. So that's the problem, right? And this can result in excess fluid and waste from blood remaining in the body, so which may lead to other health problems like heart disease and stroke. This is a blood test that we do to show the estimated glomerular filtration rate, or that's what we call the EGFR, or this is the amount of blood the kidneys filter in 1 minute. And this will determine the extent of damage in kidneys or the stages of chronic kidney disease. So we have mild kidney damage, mild to moderate. We also have moderate to severe, or we also have the end stage renal disease or the ESRD. That's why we have stage 1, 2, 3, 4, and 5, so depending on the EGFR. Now, as you can see, many doctors, most doctors would look for measures and diagnostics for us to see if the patient is really suffering from chronic kidney disease. So usually we ask for blood test. Aside from your EGFR, we also ask for creatinine and then your BUN. And then we also ask for urinalysis. Although the urinalysis is not really that specific, but looking at the proteins, if there are more proteins in the urine, specifically albumin, then that's an indicator that the kidneys are having a hard time. Okay, so protein in the urine is not actually bad, but there are certain proteins that are beneficial in terms of kidney function. But albumin in particular is the harmful protein. So the presence of albumin in the urine means that your kidneys are working overtime. So we also look at this in a way that, to inform our patients whether there is progression in the kidney, in the dysfunction of their kidneys, and so that they are also aware what's going on. Now, looking at the risk factors for chronic kidney disease, we know that it's not only protein that's associated with chronic kidney disease, but we also look at top-cited articles, that includes studies on the risk factors for chronic kidney disease. And studies would show that diabetes, high blood pressure, heart problems or stroke, obesity, of course, family history is there, the use of risky substances, particularly tobacco use, and having an advanced age. So aging 60 years old and over. But what's good news here is that most of these are modifiable risk factors, correct? So we have diabetes, high blood pressure, heart disease, stroke, obesity, and tobacco use. They're all modifiable and behavioral risk factors. That's why we had this webinar. This webinar came after the discussion on diabetes, discussion on diabetes and discussion on obesity. So that somehow you guys already know how do we manage diabetes and how do we manage obesity, so that it can help you somehow remember what do we want to do with patients with chronic kidney disease. So again, there's a good news here because this disease is actually preventable. So here, looking at the relationship between modifiable lifestyle factors and chronic kidney disease, it's not only the food that we eat, but of course, having a sedentary lifestyle. In this study, regular physical activity instead of sedentariness can reduce the risk and mortality of CKD among the patients with diabetes type 2. Now, they've also reviewed a randomized clinical trial, and then they found that dietary calorie restriction and aerobic exercise can improve the metabolic problem in patients with moderate to severe chronic kidney disease. So, diet modification has been receiving persistent attention, as most of the newly emerging keywords associated with chronic kidney disease were related to diet. Although we know that more research is needed to determine the optimal dietary patterns to prevent kidney disease and, of course, its progression. Now, here, I'd like you to take note of this. So, those, if we have, I'm sure we have physicians who are joining us right now. This is really a good resource for you, an article that presents a guide for clinicians when prescribing plant-based diets for patients with kidney disease. Plant-based foods have been identified as fundamental dietary component for health among a variety of many eating patterns. So plant-based diets are an umbrella term used to describe eating patterns that include a large proportion of plant predominant foods. So it doesn't really mean that you have to eat 100% fruits and vegetables. So there are different types of diets when we say plant-based food or plant-based diets. So examples here, I'll show you later, is flexitarian, vegetarian, Mediterranean, and some vegetarian diets. So unrefined whole plant-based foods are recommended over the highly processed forms. So we always emphasize on whole foods, and the consumption of whole plant-based foods has been shown to be useful in the prevention and treatment of many lifestyle-related diseases, including type 2 diabetes, obesity, hypertension. As we have mentioned, these are some of the risk factors in the development of chronic kidney disease. And in the recent years, the utilization of whole food plant-based diets for chronic kidney disease and its resultant complications have become increasingly apparent. So here you can see the different types of plant-based diets. So we include DASH diet. This is specific dietary strategy designed to imitate or emulate vegan diets. However, they added proportions of meat for those who are non-vegetarian. So we also have the Mediterranean diet, the flexitarian, the vegetarian, the whole food plant-based, those who are vegan, and then we also have the plant predominant low protein diet for patients with kidney disease. This is what we particularly recommend for patients with CKD. So in brief, potential explanations for a protective effect of plant-based foods have included the presence of dietary fiber. We include phytochemicals, the vitamins, the minerals, such as potassium and magnesium, and of course, antioxidants. And these are often found in plant-based foods, along with favorable changes in the microbiome. So on the other hand, substances common in animal-based foods that may have detrimental effect on kidney health may include saturated fats, sodium, phosphorus, dietary acid load, or we call it the DAL, the high protein content, advanced glycation products, the heme iron and carnitine and choline, which may lead to the formation of trimethylamine oxidase. This is a toxic compound that can contribute to atherosclerosis, cardiovascular disease, and possibly kidney disease. We will talk more about these types of diets when we get to the recommendations for chronic kidney disease, and that's included in the next part of our webinar. So don't miss our webinar after 2 weeks, right? Okay, so here you will see that there is a growing evidence again when we discuss about the role of plant-based diet in the cause, treatment, and complications of kidney disease. Now, we also see a growing evidence that are suggesting that an elevated daily acid load, or we call it the DAL, is detrimental for kidney health. So even in cases of a normal serum bicarbonate level, often occurring in end-stage renal disease, an increasing DAL or daily acid load has been associated with increasing acid retention, which contributes to the progression of chronic kidney disease. Now, the bulk of non-volatile acid production in the body comes from diet, especially the Western diets. So this favor Western diets we know favor animal-based acid-inducing foods. So animal protein is acid forming, we know that, and this is due to the presence of organic sulfur, which is found in the amino acids methionine and cysteine, which we can commonly see in animal proteins. And these are oxidized to inorganic sulfate. So this is in contrast to plant-based foods that have natural dietary alkali, which can be converted to bicarbonate. So looking at the average Western diet being high in animal protein and low in natural alkali from plant foods, they generate about 50 to 75 milliequivalent of the daily acid load for the average person, and it was found contributory to chronic kidney disease progression. So because of these findings, the recently updated Kidney Disease Outcomes Quality Initiative nutrition guidelines, so we call this the KDOQI, they suggest that increased fruit and vegetable intake may decrease body weight, blood pressure, and net acid production. Now, looking at hypertension, we know that hypertension is an important cause of chronic kidney disease. You can find it here first. Hypertension is, again, we say the second most common cause of kidney failure, but it is also a common complication of kidney disease. So that means when you already have chronic kidney disease, you can't control your blood pressure as well. So this is due to the sodium retention and neurohormonal activation. So generally, for those with and without kidney disease, plant-based diets have shown utility in the prevention and management of hypertension. In fact, the accumulation of substantial and observational and experimental evidence of plant-based foods in hypertension led to the creation of the dietary approach to stop hypertension. So this is what we call the DASH diet. And the approaches of this DASH diet is mostly plant-based with some animal foods. So the rationale behind the individual components of the diet was to have the blood pressure lowering benefits of a vegetarian diet, yet it contains enough animal products to make them palatable to non-vegetarians. So in a pair of seminal randomized clinical trials, the DASH diet and its low sodium variation, they've shown to substantially reduce blood pressure after 30 days. So do not expect to have the result as early as 1 week. So as we gather data, we can see that the result can be observed at around 30 days. So the sodium restricted DASH diet led to a mean reduction of systolic blood pressure of 11.5 millimeters mercury in participants with hypertension. And this is equivalent to the common hypertensive medication that we prescribe our patients. So another concern here with regards to prescribing plant-based diet to patients is the elevated serum phosphate levels. So we know that elevated serum phosphate levels are independent risk factor for mortality in both chronic kidney disease and kidney failure. And this is one reason why plant-based foods have been frequently avoided in patients with severe kidney disease due to concerns regarding their phosphate content. But there is a huge misunderstanding in this area. Actually, studies show that their avoidance may be counterproductive. So although some foods may have a high phosphate content, such as nuts, seeds, and legumes, there is evidence that only a fraction of that phosphate content is absorbed. So phosphates found in plant-based foods are bound to phytate, which is limiting its bioavailability in humans because we lack the enzyme called phytase that is necessary to release this phytate. So the bioavailability of phosphates in plant-based foods range between 10% and 30%. And in contrast, phosphates in animal-based foods, such as meat, fish, dairy, and eggs, are typically between 40% to 60% bioavailable, but they can reach up to 80%. But we also have to take note that phosphate absorption in plant-based foods can be increased with industrial processing, such as foods that are exposed to heat over 140 degrees. Or this is like a processing that occurs with industrially baked bread. So home cooking, no, does not typically affect phosphate bioavailability. And this is another good reason why in culinary medicine and in lifestyle medicine, we highly encourage individuals to prepare food and cook food at home. So another reason that animal-based foods are higher in bioavailable phosphate is due to the phosphate-containing food additives, that are added for taste or preservation, but can increase the amount of bioavailable phosphates by 70% to 100%. So actually, you can see the foods that are high in phosphates in the book, in Culinary MD handbook. So you can go back in there. So finally, the prospective and retrospective cohort studies have shown that those eating plant-based foods, including the vegetarians, had significantly lower serum phosphate levels in kidney failure. So I'd like to have another emphasis here, which is the fiber. So we know that dietary fiber has been known to reduce uremic toxin production for decades, right? However, this is one of the most forgotten basic and practical dietary advice for patients with CKD. Now, in this meta-analysis of controlled feeding trials in chronic kidney disease, it showed a reduction of urea and a dose-dependent reduction in creatinine levels with increasing fiber intake. So in those with normal kidney function, researchers measured on average 60% lower levels of uremic toxins in vegetarians when compared with those eating the omnivorous diet, so meaning they eat vegetables and they eat meat at the same time. So this effect with dietary fiber is mainly derived from two important factors. So first, the fiber itself, and then the second is the replacement of animal protein. Dietary fiber consumption have been shown to decrease urea levels, creatinine, and other toxins by improving intestinal motility. So that means decreasing the absorption, the toxic absorption, and increasing the fecal excretion. Fibers also improve the integrity of the tight junctions in our large intestine. So this is through the production of the short-chain fatty acids from the fibers. So this reduces the permeability of toxins and by facilitating the growth of more favorable microbiome that are beneficial. These are beneficial bacteria in our colon. So because diet is a zero-sum game, the consumption of dietary fiber, which is found exclusively in plants, tends to also result in a decreased consumption of animal protein, right? So we know that animal protein consumption, especially red meat, is associated with high production of uremic toxins, like your TMAO and indoxyl sulfate. So by favoring the growth, this is by favoring the growth of proteolytic bacteria in the gut microbiome. So finally, uremic toxins have been linked to the progression of kidney disease, inflammation, insulin resistance, and cardiovascular disease, suggesting that lowering these toxins through plant-based diets may result um, in addition with additional benefits, I mean. So despite the potential benefits of dietary fiber, however, we can see that the average intake among patients of fiber among patients having hemodialysis is about 20 to 30% lower or below the recommended levels. Now, looking at the plant-based pyramid, this is what we can see. Most of it would contain fruits, vegetables, grains, leafy greens, fats, and oils. However, among patients with CKD, we also have to be cautious and be careful in prescribing them these kinds of food. So it's one of the conditions where we really intentionally look and follow up the food intake of our patients. So both in the not only for their intake in intake of animal-based food, but also their plant-based food. So one of the potential concerns is hyperkalemia. So the National Institute of Health, or the NIH, actually recommends that healthy adults take about 4,700 milligrams of potassium daily. Although most people do not get adequate potassium in their diets, they get too much potassium from other dangerous sources. So when we have too much potassium in the blood, there can be dangerous conditions, which is called hyperkalemia. And among patients with chronic kidney disease, the kidneys cannot remove excess potassium from the blood, right? So patients with kidney disease are at risk of developing high potassium levels. And this extra potassium in the blood is passed through the kidneys and sent back into the bloodstream instead of leaving the body through our urine. So in patients with chronic kidney disease, the potassium levels in the blood can rise over time, posing a health threat. So one of the biggest concerns regarding the utility of plant-based diets in patients with kidney disease, again, is hyperkalemia, which is not unfounded, but is likely overinflated. So in a review of a case report of dietary causes of hyperkalemia, including patients with or without chronic kidney disease, plant-based items were a common culprit. No, they always blame it to plant-based sources. Although the review does not comment on the patient's baseline dietary habits to begin with. And we can see that among those studies, the bulk of hyperkalemic episodes from plant-based items in those series were related to the consumption of juices. So these are extracted juices from plant-based sources, sauces, for example, and dried fruits. So all of which actually uniquely increase the rate and the amount of potassium consumed compared to the whole food form. So for example, although a person may not be inclined to eat 2 medium oranges in one sitting, but a cup of orange juice can readily provide the potassium content of nearly 2 oranges already. So fruit or vegetable-based sauces and dried fruit, they have similar issues in this regard. And in addition, juices and sauces also lack fiber, which may be an important factor in mitigating the possibility of hyperkalemia. We know that fiber increases stool quantity, right, and frequency, which when excreted facilitates potassium excretion too. So along with fiber, plant-based foods may have additional factors that temper any increase in serum potassium levels. So for example, natural alkali in these foods may facilitate the intracellular movement of potassium, especially in metabolic acidosis. So other factors include improved insulin sensitivity and a reduction in the need for hyperkalemia-inducing medications. So finally, additional data suggests that potassium in unprocessed plant foods may not be over 60% absorbed. So based on these points, the risk for hyperkalemia may have been previously overstated, so resulting in perhaps an opportunity lost for patients to consume healthier versions of food. So it is likely that not all plant-based foods are the same in regard to their potential for hyperkalemia, but the potential culprit and substances to avoid should include juices, sauces, dried fruit, potassium-containing supplements, and foods that have unusually high potassium content, like your molasses and raw legumes. So you can actually find a guide in the culinary medicine handbook. You can find there a table that enumerates food contents that may have high, moderate, or low amount of potassium, and the same with phosphorus. Okay, so despite all these considerations, it's always reasonable to proceed prescribing whole food plant-based diet to patients with caution. Okay, especially for patients with chronic kidney disease and kidney failure. So again, when you go back to the book, you can find their tables that will describe foods that may be high, that may have high, medium, or low amount of phosphorus. And you can also see in the book the potassium-rich foods. We know that potassium-rich food may contain 250 milligrams of potassium per serving or more. So if patients are on dialysis or their doctor has advised them to eat low potassium foods, the aim should be a daily potassium intake of 2,500 milligrams or no more than 3,000 milligrams. So a physician or a dietitian may actually adjust these goals to meet the specific needs of their patients. So this is just an example which I got from the Culinary Medicine book. So these are examples of potassium-rich foods which have more than 200 milligrams of potassium per serving. So they may include most vegetables and fruits, the beans, and majority of the meats, majority of seafoods, products derived from milk, chocolates, and nuts. So there are also foods that have low potassium levels, which means they have less than 100 milligrams of potassium per serving. So that includes the cauliflowers, onions, cucumbers, fruits such as apples, bananas, and blueberries. And this also includes pasta, bread, and rice. So you'll be surprised because you can find banana as low potassium food in the list of low potassium food, which is less than 100 milligrams of potassium per serving, right? But most people thought that bananas have the highest number or amount of potassium per serving. Okay. All right. So we will go back to this table next meeting in our next webinar because we wanted to talk more about diabetes type 2, diabetes mellitus, and then how this disease can progress in relation to lifestyle and dietary intake. And then most importantly, we'll be talking about food preparation. How do you act? What kind of cooking methods do we usually advise patients, to prepare their food, especially for patients with chronic kidney disease, maybe to decrease the AGE production, or maybe to decrease the bioavailability of phosphates, because we know that food processing can actually influence its bioavailability. Okay, so we will be talking about that in the part 2, of our discussion with chronic kidney disease. So please reserve your questions for chronic kidney disease in our next webinar. Again, that will be coming up. I think it's March 23. So again, we'll be talking and I will be emphasizing more on proteins and other factors. And of course, the practical dietary recommendations. And we will see what are the lifestyle programs available for chronic kidney disease management. Okay, so again, this webinar is also in collaboration with the Philippine College of Lifestyle Medicine. If you are a trainee in lifestyle medicine, you can get a CME credit for this, and also for the members of Philippine College of Lifestyle Medicine. You can also visit our website remnant-institute.com if you wanted to know more about programs or lifestyle medicine programs for specific kinds of diseases like chronic kidney disease. So again, this webinar is brought to you by Culinary MD, and you can see you can visit our website and see free resources, the past webinars that we have had. So we usually upload our past webinars, recorded webinars already, so that you guys can access them or view them again. Now, if you do not have the copy of the Culinary Medicine Handbook yet, you can visit Amazon KDP if you want the ebook form, or maybe you want to give this as a gift to a loved one who has chronic kidney disease or some conditions that are included in the handbook. So this book is over 400 pages, which includes over 100 of recipes which you can try at home. So if you're not into culinary medicine training yet and you might be interested, then maybe you can visit the website and check on the courses available. We have a free course that you can try out first. And then when you get interested, maybe you can go for a basic course. Or if you really want to have a certification and add this in your credentials and in your practice, then you can go for the professional course. Of course, you can always apply for the scholarship grant under Culinary MD. Just send them, our secretariat, an email so that they can assist you through this. You can also reach us in Facebook and send message so that our secretariat can respond to your questions. Again, the next webinar will be March 26th. That's it. So we'll be talking the rest of the topic for food first approach for chronic kidney disease. Again, this is Dr. Mechelle Palma, the founder of Culinary MD, and I'd like to thank you for joining me this evening. I'll see you next time. That will be March 26th.
Recording in progress.
Culinary medicine is not a gourmet cooking. It pairs the art of food preparation and the science of medicine. It is the practice of helping patients use nutrition and good cooking habits to restore and maintain health. It's about teaching the why and the how behind low-cost, convenient, health-promoting, and delicious home-cooked meals and healthy eating patterns. Culinary medicine offers a simple approach to understand how food and cooking relate to personal health, behavior, and healthcare goals. It is as much about learning which food reduce inflammation and promote melting of cholesterol plaques in our blood vessels as it is about how to properly slice the onion and cook food with rich flavors and enticing plate preparation. More importantly, culinary medicine offers individuals an opportunity to practice culinary skills and taste new recipes alongside with health education, and all of which is taught in a way that effectively translates to their own home kitchen. The objective is to educate about the powerful influence that food has on health and disease. The goal is to establish skills in preparing meals with nutritional benefits and develop the habit of being a smart consumer, someone who would always consider what follows after every swallows. The curriculum is designed not only for healthcare providers, but most importantly, for patients and their family. Culinary medicine is purely an evidence-based field of medicine. In fact, a growing number of medical schools in the United States are increasing the education provided to their students on clinical nutrition and bringing medical students in the teaching kitchen. As we speak, more and more medical practitioners and lifestyle medicine service providers are seeking the certification in culinary medicine. And now, the Philippine College of Lifestyle Medicine finally brings culinary medicine certification course in Asia. It is a program with a blended curriculum composing of online and in-person modules that anyone can finish between 6 to 12 months at their own pace. The online component will provide foundational knowledge in culinary skills, behavioral coaching, and clinical nutrition for specific group and specific disease. There will also be a remarkable emphasis on chronic disease prevention and reversal, such as diabetes, heart disease, dyslipidemia, basing on published evidences. Bottom line is, culinary medicine is a course that should be taken by anyone who has the risk or who already have the chronic disease, where the cost is mostly within the control of our lips. See the link, register, and get your kitchen ready.